This lecture covers traumatic brain injury. In the next lecture, we'll talk about spinal cord injury. Now, both of these are going to involve mechanical injury to the central nervous system. In traumatic brain injury, like spinal cord injury, we can have motor and sensory deficits as a result of the injury. But unique to traumatic brain injury, we can also have cognitive deficits that occur. The spinal cord is largely sensory and motor relay, bringing sensory information from the body into the brain and motor commands from the brain out to the body. That's not where the magic happens. Aside from a few reflexive arcs that are built in there, not a whole lot is going on in the spinal cord as far as information processing. Largely that's going to be carried out in the brain, and so traumatic injury to the brain can cause a host of symptoms. In the image shown here, we're looking at Phineas Gage. And Phineas Gage is a famous case of traumatic brain injury caused by projection of a railroad spike through the left orbit, so going from the cheek up through the eye and out the top of the head, landing, 60 feet away, or whatever the folklore is about it. So Phineas Gage was working on the railroad all the livelong day when an accidental explosion sent a railroad spike through his brain. As a result of the injury, his behavior changed because he had damage to his frontal lobes. And we think of the frontal lobes as kind of organizing our behaviors and making sure that we have socially appropriate behaviors. And as the story goes, Phineas went from being a very mild-mannered, well-behaved man to a gambler, swearing in public, and unable to hold down a job. Something along those lines. So traumatic brain injury can cause a variety of issues, depending, of course, on the site and the severity of injury. We'll talk about some of the symptoms in the first part, and then we'll talk about how the injuries occur, which is really just going to be a restatement of everything we've had in this class. There's no more ways to kill neurons than we've already covered. So in the first part, we're going to talk about the problems that can occur as a result of traumatic brain injury. There could be sensory problems, motor issues, or it could be something outside of that, where it's a change in your behavior, like with Phineas Gage. Memory issues are not uncommon. And as the injury creeps lower down and approaches the spinal cord, once we hit the brainstem, then we can have deficits with vital functions. So what this slide is showing us is the prevalence of traumatic brain injuries, or the incidence, I should say, of traumatic brain injuries across a few different years. So the plot on the left is showing us from, it looks like 2001 to 2010, and data from 2013 are shown in the plot to the right. So there's a few lines to make sense of. The first one I want you to look at, plot on the left, we got a purple line there. That's just everything added up together. So whether it's a visit to the emergency room, hospitalization, or death, any one of those three that's caused by a TBI, that's shown in purple. The blue line is showing you emergency room visits, and you can see that closely mirrors the purple line, just drop down a little bit. The red line there is showing you hospitalizations, so long-term stays there. And if you add the blue and the red, you pretty much get the purple. So the colors make pretty good sense here. Aside from that green, I tend to think of death as a bad thing, so I would make that red. But anyway, the green line is showing you deaths as a result of TBIs. And what you'll notice is that even though the purple line is on the rise there, the green line is actually falling. So we're getting better at managing traumatic brain injuries, so that they have become less lethal over time. Now, as far as the scale here goes, that green the green lines go to the right axis, and everything else goes to the left. So because of the different scales on the two y-axes, that's why the green line doesn't really do anything to change the purple line. The plot on the right I've constructed from 2013 data from the CDC. just showing you across different age groups, how do the outcomes look? And again, deaths are going to be shown on their own scale bar because deaths are far less common than just injury from a TBI. You can see that deaths become far more common as you get older. As with most things in life, aging doesn't help. And you can see that the emergency room visits, hospitalizations, we're going to see a little bit of a difference across time. So hospitalization, it kind of follows the trend with death. It increases across age. Emergency room visits are going to have kind of a drop there, so that whenever you're in your kind of middle adulthood, so early to late adulthood there, adults have the kind of the lowest rates of emergency room visits compared to those that are much younger. When it comes to TBIs, the elderly are going to have the highest instance of hospitalization and death. And this is true for pretty much any disease, whether it be a mechanical injury or even viruses that are floating around. The elderly tend not to do as well. Now, those deaths that occur as a result of traumatic brain injury are going to have different causes, and that's going to vary with age. So in the youngest age groups, the most common cause of TBI-related deaths would be child abuse, which gets categorized as assault here in this plot. Once we enter about school age, we see a drop in assault-related deaths, and here it's really just going to be motor vehicle accidents. And motor vehicle accidents are going to dominate the causes of TBI-related deaths up until later adulthood. Once we get into later adulthood, then it's more self-inflicted TBIs. So self-inflicted gunshot wounds, for example. You see these tick up in the older age groups, and falls really become a problem whenever we get into elderly populations. Here, falls are going to be the more common cause of TBI-related deaths. So again, we have different scale bars on the y-axis there, so even though in that 75 plus category, the red isn't quite as high, you'll notice that it's on a different scale. So it actually far exceeds that self-inflicted bar there. Now, not every TBI is, of course, going to be lethal. Most of them aren't. And most of them are going to be what we call mild TBIs. So a mild TBI would be a concussion, for example. And while there's no real way of diagnosing concussions definitively, we look for really a change in cognitive function. So we're going to look for disorientation, any dizziness, nausea, vomiting, changes in mood, attention, memory. Those are all going to be indicative of concussion. Of course, headache can occur. We're dealing with head injury, so it's not uncommon to have pain in the head as a result. The best way of looking at the onset and the offset of concussion really is to just track mental function. And so for athletes, it's really important to have the kind of yearly or biannually testing to get baseline scores in cognitive function. So if they suffer a head injury, you can then track the onset and the resolution of those symptoms. So we have an example shown here in this slide. You can see they have baseline scores looking at memory function, either verbal, visual, reaction time, a few different cognitive tests there to get sort of where does this person stand when they don't have a head injury. After a head injury, if there's concussion, we're going to see a decrease in the scores, or an increase, whatever worse means. So your memory scores are going to drop, your reaction time is going to increase because you have slowed mental function as a result. And as the concussion resolves, you'll see a return to normalcy. But as I've said before, we're all snowflakes, so one person's normal for memory is going to vary substantially with another person's normal. So the annual or biannual testing to get baseline scores is important, especially for those in at-risk groups. So anyone who's prone to a head injury, military personnel or professional athletes are going to be subject to this testing here. Now, depending on the site of injury and the severity, we're going to get some mix of motor, sensory, and cognitive impairments. So the cognitive impairments could be problem-solving abilities, attention, of course, reaction time. Memory is also a big part of that, and just your decision making. So impulsivity may come about after a traumatic brain injury because decision making is impaired. Mood disturbances are also not uncommon. Now, as far as memory goes, there's really two major types. So it could be anterograde or retrograde, and those deal with relation to the injury. So the loss of memories that were already there, that would be retrograde, and then the inability to remember information after the injury would be anterograde. And the whole reason that we have this amnesia is because of damage to the hippocampus or associated structures. Right here in the medial temporal lobes, we have the hippocampus, and this is the brain region that kind of keeps a running tab on our life. It stores autobiographical memory. It helps us organize events in time so that we know what's happening now, what happened before. And when you have damage to the hippocampus, your autobiographical memory suffers as a result. Also not uncommon would be pain. Of course, pain in the head and neck are to be expected after a head injury, but long-lived neuropathic pain can also result whenever there's damage to the thalamus. And most commonly what we're dealing with is damage to the ventral basal complex. So we'll talk more about this next semester, but just very briefly, our painful and non-painful sensory pathways are a little distinct, and we've talked about these already. So you have your spinal thalamic tract and the posterior column medial meniscus pathways. Pain, not pain. Now these are going to hit different areas of the thalamus and the cortex, and that's why they produce different perceptions. Pain and non-painful stimuli don't feel the same. That should be fairly obvious to all of us, and that's because they hit different parts of the nervous system. So pain is going to hit areas associated with emotion, so that pain sucks. We have an emotional response to pain. We don't like it. It feels unpleasant, and that's because of the emotional response there. Not a whole lot of emotional response to the non-painful input, with some exceptions. But for the most part, all we're doing is getting a sense of where's my body, what am I feeling. Not a whole lot of emotional response there. The reason that they're going to hit different parts of the cortex is because they're going to hit different parts of the thalamus. Now both of these are going to hit the ventral posterior lateral and medial nuclei. So the thalamus is this big complex of different regions, and that's shown here in this slide. That little inset is showing you a bunch of different thalamic nuclei. So these two pathways converge here, and this just creates that body map of where do we hurt or where are we feeling non-painful stimuli. So this is how we localize where. But in order to get that emotional response and to learn from the pain, that's also very important. If you touch something and it hurts you, you quickly learn not to touch that again. And that's because we're going to hit other areas of the thalamus as well with these painful pathways. One example would be the mediodorsal nucleus. And this thing is tied in to your limbic system, which is where we create our emotions and memory. The hippocampus is a part of the limbic system. So why is it so easy to learn not to touch fire after you do it once? Well, that pain stimulates our learning and emotion circuits. That would be our limbic system. And the middleman there would be the mediodorsal nucleus of the thalamus. There's some other targets as well. We'll talk about those next semester. But you can see they don't hit the same areas. There's some commonalities, so we know where. But the extra aspects of pain, that emotional response, and the learning that occurs. That's because of different brain areas getting activated. So the reason that pain feels different is because it's hitting different areas of our brain. So when we have damage to the thalamus, particularly in the ventral posterolateral or ventral posterior medial nuclei, this is going to cause some sensory deficits. So we won't be able to feel as well. We'll have some loss of tactile sensation, but what we'll also get is long-lived pain. And this is because everything is a comparison. Everything's relative. If you've ever seen those illusions where there's a spinning disc and you look at it for a while and then you look at some words and the letters are kind of moving around, that's the same thing. The reason that we see movement is because we have neurons that are responsive to different directions of movement. Left, right. If our right responsive neurons are more active, we perceive movement to the right. Even if it's not moving, we'll still perceive that movement. That's the way that these illusions are going to work. What they're going to do is exhaust, let's say by spinning this way, they're going to exhaust the left responsive neurons at the top and the right responsive on the bottom. Right? We're spinning this way, so when the spinning stops, those exhausted neurons have a lower level of output than the non-exhausted neurons. So we get the sense that things are moving, even though they're not. Same thing here. When we damage the thalamic nuclei that relay non-painful sensation, and we keep intact some of those that are relaying painful sensation, that balance of pain and non-painful sensation gets thrown off. So we feel pain, even though there isn't any. It's all relative. And so when we lose one half of the equation, well, that biases us toward feeling pain. Alterations in consciousness may occur following a traumatic brain injury, and if they do, this is indicative of poor prognosis. More severe brain injuries are going to lead to coma. Less severe can cause a little bit of grogginess, that disorientation that was brought up before with concussion, and the very mild forms might have absolutely no effect on mental function. We can, of course, assess the level of consciousness using that Glasgow Coma Scale. I'm sure you're aware of this. You look at eye movements, you look at motor responses, verbal responses, added up. Anything 8 or less, you got a coma. 9 to 11, moderate. Anything greater than 11, minor head injury. Now, the reason for this is most likely because of damage to the ascending arousal system. And we've brought this up before. So this is a collection of neurons in the brainstem that are going to create arousal. And they're going to ascend through the midbrain. So, let's see here. We got our pons, medulla, going down to the spinal cord, which we don't care about yet. We'll care about that in the next lecture. The ascending arousal system is going to be made of neurons spanning the brainstem, and they're going to project upward. Some of them will hit the thalamus, some will hit the basal forebrain, others are going to project widely throughout the central nervous system. And what they're going to do is increase the activity of our cortex so that we're awake. When we have damage, most commonly in the midbrain where we've collected all these axons together, that's whenever we get coma. Because that ascending arousal has been lost, we don't have sufficient excitatory drive to the cortex, we don't have conscious awareness. Most commonly this occurs because of damage to the midbrain. If it's just a little bit of overexcitation leading to a block in nerve cell output, this could be transient. If it's actually severing of those axons, then you can have long-lived coma. You can identify the level of injury by carrying out a few cranial nerve exams. So where do we have our injury leading to that coma? One of the things you can look for is just an increase in intracranial pressure. So what he's going to do is use the ophthalmoscope there to have a look at the optic disc. If he sees bulging of the optic disc, that's going to be an indication of an increase in intracranial pressure, because as we increase pressure here in the brain, that pressure is going to push on our optic nerve, bulging out the optic disc there. So this can tell us whether or not we have elevated intracranial pressure, because in a comatose patient it can be hard to look for those signs. We can also look for some cranial nerve reflexes, such as blink to threat. So he's going to show you that here. You just simply poke a finger at someone. You can't do it to yourself because you know you're not going to poke your eye. But you can get with a friend, of course, not right now, unless you have really long arms, and then just poke. If their vision is working, they'll be able to blink there. Moving on down to now include the midbrain and bring in that third cranial nerve, we can look for pupillary responses. So if the midbrain is intact, we're still going to see changes in pupillary size. So when we shine a light, we should see constriction, and it should be in both eyes. So we should see the direct constriction and also the consensual constriction in the eye that's not getting light. We can include some additional cranial nerves, so we'll move a little further down to include now the pons here and that junction with the medulla as well. So we're looking at cranial nerves 3, 4, and 6 to control the eyes, and then cranial nerve 8 to sense head position. So the cranial nerve 8 is the vestibulocochlear nerve. Here you can see as he's turning her head, she's able to fix her gaze forward. So the 8th cranial nerve senses movement of the head, and then it recruits through the vestibular nuclei cranial nerves 3, 4, and 6 in order to move the eyes in an opposite manner so that we can keep our gaze fixed. And this is working for us all the time. This will remain working for you so long as you don't have damage anywhere in this area. So if you have brainstem damage, you should see alterations in that reflex. Here's the corneal reflex. So here we're now adding the trigeminal nerve. That's going to sense stimulation of the cornea, and then it's going to trigger blinking through the 7th cranial nerve there. There we're down in the pons. Getting further into the medulla, we can look for the gag reflex. So with that, you stimulate the palate, and you should see bilateral movement. So it should be symmetric across both sides there. That's enough of that. And this is just showing you the position of the different cranial nerves. So we've just gone from top to bottom with those different cranial nerve tests. And that can help us identify where do we have the lesion or the damage. You can also identify the location of injury by looking for different postures. So in unresponsive patients, you can see abnormal posturing depending on the site of injury. So anything above the midbrain, so here's our midbrain here, any injuries above it are going to cause decorticate posturing. This is different from decerebrate posturing in terms of the upper limbs. And that's because we still have our rubrospinal tract intact. So the red nucleus in the midbrain projects down to the upper limb flexors for the most part. I don't think they do much else in humans, but in other animals this is kind of like a backup to the corticospinal tract. So it's probably a more ancient motor pathway, which we don't really use anymore. But you'll see it in action when you have damage above the brainstem. So the rubrospinal tract, rubro meaning red, so it's going from the red nucleus down to the spinal cord. The rubrospinal tract is going to cause flexion of the upper limbs. When you have damage at or below the midbrain, you're going to, of course, sever the rubrospinal tract, and you'll lose that flexion and get extensor posturing. So long as the injury is confined to the brain, you should still have spinal reflexes intact. That's all that bottom panel is showing us here. So you should still be able to see spinal reflexes if it's brain injury as opposed to spinal cord injury. If we have damage down here in the medulla, we're going to see changes in respiratory patterns. So normal breathing, we're going to have fairly steady breathing that occurs, but we can see different patterns of ventilation whenever we have damage to our respiratory centers down in the medulla. There's also some in the pons as well to help organize it, but it's okay to just think of the medulla here as controlling respiration. It's more accurate to think it's the medulla and the pons. Medulla being number 1, pons being number 2 in this case. Pons respiratory neurons are really just going to act by controlling the medullary neurons, and then these neurons innervate the lower motor neurons that allow us to breathe. Now the patterns that you see, there can be a few different types. So the Cheyne-Stokes breathing, we're going to see an oscillation, so there's going to be kind of bursts and pauses. As opposed to that kind of steady ventilation, you'll get periods of high ventilation rates and then holding of the breath. Hyperventilation would just be the burst, just increased rates of hyperventilation. Then you can get prolonged pauses without the bursts. That'd be the apneustic breathing. And then it could just be irregular, and there's no real pattern to it. That would be ataxic breathing. This is a little more common with medullary damage. When you have damage to the medulla, you'll also see alterations in cardiovascular regulation as well. You'll see what we call Cushing's triad. So whenever we have damage to the medulla or increased intracranial pressure that's pushing on the medulla, that will give us our irregular respiration, which we just went over. So that's one component. Now, whenever we have that increase in intracranial pressure, this can also then lead to hypertension. So we're going to get an increase in blood pressure, and what we're going to try to do there is increase the amount of blood flow to the brain. We're going to try to overcome that intracranial pressure so that we keep getting blood to the brain. As a result of that hypertension, we're then going to see a slowing of the heart rate as a compensation to that hypertension. So those are your three components of the Cushing's triad there. Now the prognosis really can be summarized as how bad was the injury. The more severe the injury, the poorer the prognosis. That's really what all these come down to. The severity of your impaired responsiveness or altered consciousness. That depends on how severe the brain injury was. Any amnesia that occurs, the severity of that depends on the severity of damage. So these different factors here are all ways of looking at damage. So it's a way of looking at symptoms and then estimating damage. So in general, the worse the symptoms, the worse the damage, the worse the prognosis. Aside from the damage and the problems that occur kind of immediately, after the fact, within about a week, if multiple seizures occur, so if epilepsy occurs, this is indicative of a more severe injury and thus poorer prognosis. Any sort of bleeding that occurs, either in the brain or nearby, if you get hematomas, they're going to increase intracranial pressure and displace brain tissue. That's what we're seeing here. So here we're looking at a subfalcine herniation here, so we're pushing over the cingulate gyrus. It's crossing midline. We can clearly see that it's crossing midline here. So this is a CT scan. We can tell that because the skull is so prominent. Bone shows up well in CT. Our ventricles should be nice and bilateral. But in this case, what we're seeing is that they're pushed over right? Where that lateral, the two lateral ventricles, that one on the right is essentially just getting squashed because we're getting this hematoma forming here, placing pressure here, and displacing that lateral ventricle. So this should be empty, well, this should be filled with cerebrospinal fluid rather than brain tissue. So when we have that increase in pressure here, what it's going to do is displace us across midline. This is a very clear indicator of an increase in intracranial pressure. Of course, the older you are, the poorer the prognosis. Not many things get better with age, other than your finances and your ability to regulate your emotions. Those generally increase, but everything else gets worse for the most part. And of course, a history of brain injury or psychiatric disorders is also going to indicate poor prognosis. Repeated injuries are, of course, never a good thing. And that's because whenever you have a traumatic brain injury, the injury itself, as well as the response to it, is going to contribute to TBI. So early on, that initial injury, that primary injury, that's of course going to cause brain damage due to mechanical forces. So here we're looking at really necrosis. So on the left we can see an open injury. In other words, the skull has been penetrated. So here we can see this is from a gunshot wound to the head. So there's hematoma forming on the left. You can actually see the bullet still there, and you can see the lines where the shrapnel has moved through the brain there. On the right, we're just looking at a closed injury, so the skull remains intact. But there's been severe enough mechanical force moving that brain around that what we're doing is really kind of pulling on axons and shearing them. When we're talking about the closed injuries, really what we're dealing with is the tearing of axons. Undoubtedly that's going to occur with open injuries as well. But with closed injuries, it's not so much that you have physical force coming in and ripping open membranes. It's the movement of the neurons themselves that's causing that. It's the rotational forces that are stretching axons and causing them to break. Because as we rotate, there's going to be a different degree of force placed on the brain there. So if this is our point of rotation, as you move further away, the amount of displacement is going to increase. So right here, there's not going to be a whole lot of movement. A little more movement, more movement, more movement. So you get asymmetric movement of axons. And of course, there's going to be the force. Once the head movement stops, momentum is going to carry that forward, and then you're going to have the reverse movement. So there's the movement of the head, the stopping of that movement, and then the movement back. Both of those are going to place mechanical forces onto axons that can shear them. And that's really what we're going to see with traumatic brain injury, is the breaking of axons. And that makes sense. When you think about the size of a cell body and the dendrites relative to the axon is much greater for a neuron than the cell body, which has about a 20 micron or so diameter. The dendrites, which are going to, they'll be several hundred microns, but the axon can span great distances. If we're talking about axons in the cortical spinal tract, for example, they have to go from the cortex down into the spinal cord. So it's just a matter of the axon covering a much greater area. Because there's more axon than the rest of it, it's a more likely site of injury. And these data here are showing us the loss of axons following head trauma. What we're looking at here is diffusion tensor imaging. This is a form of MRI that looks at the diffusion of water. Now, of course, when you have a bundle of axons, a bundle of myelinated axons, I should say, that myelin is, of course, fatty. and water can't move as well through fat. So any of the water molecules that are floating around here, they have restricted diffusion. They can't diffuse up or down, as I've drawn it here, but they can diffuse left and right really well. So by looking at the movement of water, we can retrace axon pathways, and that's what they've done here. So on top we're looking at normal axon pathways, and what we're looking at really here is the corpus callosum. So the white matter that connects the two sides of our hemispheres. So our two sides are working together because of our corpus callosum. What you can see here are, on the bottom, are two obvious sites where we've lost some axons. Now not every axon is going to be stretched enough to die, so we're going to get a mixing of living and injured axons. When we have injury to the axon, let's say here, what we're going to get then is degeneration of the axon moving forward. Now the problem with injury to the central nervous system is that it's very difficult to regrow our axons because the myelinating glia, those oligodendrocytes here, say here's an oligodendrocyte, what they do is inhibit axon growth. So when we're born, there's not a whole lot of myelination. Myelination comes later on. So we don't myelinate until after we've grown our axons out, and that makes sense. If we don't have axons, we can't myelinate them. Throughout development, what the central nervous system does is restrict the ability for axons to grow, and what it does is thus lock the pattern in place, so that as you're learning information, you don't all of a sudden just forget it, because you're rearranging your nervous system all day, every day. We have very subtle changes in our connections. Nothing too major. So we're not going to get a lot of axon regrowth in the central nervous system. It's different out here in the periphery. The axons can regrow because we have a very simple setup here. Just go get your target and hopefully find the same one you had before. But it's a little more complicated in the central nervous system. So when we have damage and the loss of axons, they're pretty much gone. And we can see that here. After the head injury, we see the loss of axons, and they're going to be gone for good. Now the secondary injuries are going to be caused by the response mechanisms to that primary injury, or the aftermath of that primary injury. So not just the mechanical forces, but how have those then affected the nervous system? For example, alterations in cerebral blood flow. This would be a secondary injury. The primary injury is whatever is causing it. Maybe most likely a fall, but it could be a penetrating wound, although that's not as likely as just a fall. Aside from mechanical forces, after that, then we have our secondary injuries. So if we have hemorrhage, and we have then a hematoma forming, that's what we're seeing here. In this image, very large hematoma. You can see we've displaced the midline. That's what I've drawn with that dotted line there. You can see the corpus callosum has been shifted over, so that white matter bundle has been shifted to the right there. That increase in intracranial pressure that's occurred is going to affect blood flow, because the central perfusion pressure, or CPP there, is going to be the difference between our blood pressure and intracranial pressure. So if our arterial pressure is not greater than intracranial pressure, we don't get blood into the brain. The cerebral perfusion is going to drop as a result. And that's why we'll get that increase in blood pressure as a part of Cushing's triad there. So that's a response by the body to help keep adequate blood flow to the brain. Whenever we increase intracranial pressure, obviously that's going to drop our cerebral perfusion. Now, as we get these mass lesions forming, they don't immediately cause an increase in intracranial pressure. We have some compensatory mechanisms there that make the relationship between the size of that lesion and the increase in intracranial pressure nonlinear. So as the lesion increases in volume, what we can do is just displace some non-essential fluids. So we can decrease CSF volume, for example. And what that'll do is cut down on the amount of stuff that's in our head and thus decrease the pressure. But we can only do this for so long, and once we exhaust that, then we can have dangerous rises in intracranial pressure. The rough ballpark is about 20 millimeters of mercury as being the intracranial pressure that requires intervention. Whenever we have traumatic brain injury, our ability to regulate blood flow is also impaired in the central nervous system. So we can dynamically change the size of our blood vessels in an activity-dependent manner. So whenever we have an area that's more active, we can shift blood flow to that area. For example, if you were to look at one of those visual illusions and you strongly stimulate your visual cortex, we'll see an increase in blood flow to the visual cortex because of the increase in activity there. And that's because neurons are able to then communicate with the smooth muscles in our vasculature. They do that directly, they do it indirectly as well through astrocytes or through epithelial cells. And the production of nitric oxide by the epithelial cells, which normally stimulates vasodilation, this nitric oxide production is impaired. So the epithelial cells are going to be less responsive to input from neurons. Well, maybe they're just as responsive. It's hard to say. We don't really know why this occurs. But the production of nitric oxide as a result of neuronal activity drops. So what we see then is vasoconstriction. So decreased blood flow to the brain, either because of an increase in intracranial pressure or because of this impaired regulation of our blood vessel diameter. Now, of course, brain injury that increases intracranial pressure or affects blood flow can then lead to excitotoxicity because of all those different things that we talked about in this class. So you can have mechanical stimulation. If you put pressure on a neuron, that'll force open ion channels. That lack of blood flow can deplete ATP, and there you get depolarization, leading to excitotoxicity. Any damage is, of course, going to have to be cleaned up, so you get reactive gliosis. That can kill off neurons just like it has in every other lecture. Now, if we have mass lesions forming, you can see herniation of brain structures. And there's different types of herniation. Some are more severe than others. Again, if you're affecting the brainstem, more severe. So up top, that subfalcine herniation where we're pushing over the cingulate. This is, of course, not a good thing, but since it's not affecting brainstem, not as likely to be lethal. As you move on down there, you can get herniation that may affect our respiratory structures. So if we push the midbrain upward, probably not a big problem. The central herniation where we're pushing the midbrain downward, that can be a problem. Uncal herniation, not related to ant herniation, that's where we push the uncus downward. So the uncus is that more medial portion of the temporal lobes. If we're pushing stuff downward, no matter what it is, whether it's midbrain, temporal lobes, or the tonsils of the cerebellum, if we're pushing on our respiratory centers, we run the risk of having impaired breathing. And that's going to be a major problem. Now, even mild injuries can pose a problem if they're repeated. Repeated head injuries are going to cause chronic traumatic encephalopathy, at least in some cases. And it's really hard to say how long it takes and how severe the injury needs to be. We don't understand a whole lot about it at this point. But chronic traumatic encephalopathy is really kind of an injury-induced Alzheimer's disease. Because we see plaques and we see tangles. And the risk factors are basically the same. If you have that ApoE4 allele, you have a higher risk of developing chronic traumatic encephalopathy, and you have poorer outcomes as a result. We see our extracellular plaques. We see degeneration of the cortex. So we get cognitive impairments, dementia. It essentially looks like mechanically induced Alzheimer's disease. Ultimately, of course, the death of neurons is going to be caused by that impaired the impaired intracellular transport due to the formation of neurofibrillary tangles. and then the tau deficits that we talked about in Lecture 7. So there's a lot of similarities in terms of how we kill off neurons, because we've already talked about every way that that happens. So I got a few review questions for you here. If any of those seem tricky, fill out the questions box, or it's probably more appropriate to send me an email now and I'll respond to those. I'm going to set up a time to have some virtual office hours, so be on the lookout for an email there. Hopefully I'll see you later.